2, 1. Good afternoon. The committee will come to order. Without objection, the chair is authorized to declare a recess of the committee at any time. I now recognize myself for an opening statement. For the past 2.5 years, the Select Subcommittee has devoted itself to investigating the effectiveness, efficiency, and equity of the nation's response to the coronavirus crisis. Our committee was formed in April 2020. At the moment of the deep devastation and great uncertainty caused by the dual threats of a deadly virus and resultant economic catastrophe. Modeled after the Truman Committee, which rooted out causes of waste, fraud, and abuse after World War II. We sought to identify and stop those who would take advantage of our vulnerabilities during that terrible time and to make real improvements to our pandemic response. During the past 2.5 years, we have investigated all aspects of how the crisis impacted American lives and livelihoods. We have held 42 hearings and briefings, released 37 reports and analyses, and heard testimony from dozens of key officials. Today's hearing will explore how to use the lessons that our committee has learned during the crisis and its aftermath to make sure we are prepared for the future. The coronavirus crisis was the worst public health crisis our nation has faced in more than a century. In the nearly 3 years since the first case of COVID-19 was confirmed in the United States, more than 100 million Americans have been infected with the virus, some with lasting consequences. And over 1 million Americans have lost their lives. The United States was hit much harder than its peer nations, suffering a significantly higher mortality rate than countries like Australia, Germany, and Japan. Compounding this devastating loss, as Americans took difficult yet necessary precautions to protect themselves and their communities from the virus, tens of millions of Americans lost their jobs. Millions more saw their hours and incomes reduced, or their small businesses closed during this time. Many of these Americans struggled to feed their families and to stay in their homes. This outcome was not inevitable. Our nation entered the coronavirus crisis unprepared for its magnitude. Our nation's public health infrastructure was underdeveloped well before the coronavirus pandemic. Elderly, minority, rural, and low-income populations were particularly vulnerable because of long-standing health and economic disparities. On top of these existing vulnerabilities, the previous administration chose to minimize the coronavirus and discourage proven health measures while undermining the scientists leading the pandemic response. But today's hearing is not about looking back. We must take stock of what we have learned so we can determine how to move forward. Based on the committee's 2.5 years of oversight work, our final report, which we will consider and adopt immediately following this hearing, includes 30 recommendations that inform what we need to do to prevent and prepare for future crises. We must invest in next generation tools, including vaccines and treatments, to be prepared not only for future variants of the coronavirus, but for other unknown pathogens that may reach us in the future. We must strengthen supply chains, increase domestic manufacturing, and ensure our stockpiles are well supplied to make sure essential workers are not left exposed when the next emergency comes. We must enact universal paid sick, medical, and family leave to help Americans protect not only their jobs, but the health of their families and co-workers in times of need. We must improve the federal government's ability to deliver emergency relief to Americans and loans to businesses during times of crises, while also improving our ability to protect relief programs from fraud. We know that the coronavirus crisis is not the last public health or economic emergency our country will face. But there is more we can do to prevent the next emergency and to be ready when it happens. I want to thank all our witnesses for testifying today. I look forward to hearing more about the actions that we can take now to prepare for and prevent the next public health emergency. I now recognize the ranking member for his opening statement, who I think is going to be Mr. Jordan.
Thank you, Mr. Chairman. The title of today's hearing is Preparing for and Preventing the Next Public Health Emergency, Lessons Learned from the Coronavirus Crisis. Lessons learned, I think the key lesson learned is that Dr. Fauci misled the country, and he did so right from the get-go. By February 1st, 2020, Dr. Fauci knew 7 fundamental facts, represented by the first 7 posters behind me, 7 fundamental facts that he did not share with the American people. First, he understood that American tax dollars went to eco-health, and that money was then funneled to a lab in Wuhan, China. Second, he knew eco-health was given an exemption from the pause on gain-of-function research. Third, the security standards at this lab in China were deficient. Fourth, Dr. Fauci knew that EcoHealth was not in compliance with their grant reporting requirements. They weren't adhering to the contract. Fifth, gain-of-function research was in fact being conducted in the lab in Wuhan, China. Sixth, the P3CO interagency review process wasn't followed in approving the grant to EcoHealth. And finally, 7, Dr. Fauci likely knew, let me say it the other way, Dr. Fauci knew that the virus likely came from the lab that our money was sent to. So think about it. American tax dollars went to a company that wasn't properly vetted, that didn't comply with its contract, who sent that money to a lab in China that wasn't up to code and was doing gain-of-function research. And what happens? The very city where that lab is at, a deadly virus breaks out, a deadly virus that would ultimately kill 6 million people around the world. And what did Dr. Fauci do when he had this information, again, February 1st, 2020? What did he do with this information? Did he tell the President of the United States? Did he go to the Commander-in-Chief and said, hey, we got a deadly virus that's broken out in China, in Wuhan, where we've been sending American tax dollars to a lab that's not up to code, that's doing gain-of-function? Did he tell the President of the United States? Didn't tell the President. Did he tell the Chief of Staff? You know, maybe he thought, you know what, I don't want to take this bad news to the Commander-in-Chief. Maybe I'll give it to the Chief of Staff. I know he'll tell him. He talks to him every day. Did he tell the Chief of Staff? Didn't tell him either. How about the experts in our government? Did he tell his boss? Did he tell Secretary Azar? Did he tell Dr. Redfield, Dr. Birx? Did he tell Dr. Giroir, one of our witnesses today? Didn't tell any of them either. No, what he did instead was organize a conference call February 1st, 2020, 2 p.m. with him, Mr. Collins, and 11 virologists from around the world who he had been handing out American tax dollars to for years and years and years. And on that call, it's interesting. On that call are a couple virologists, Dr. Gary, Christian Anderson, who had said things like this. Here's what Christian Anderson said: virus looks engineered, virus not consistent with evolutionary theory. He said that on January 31st, the day before. Dr. Gary said on February 1st, that very day they had the conference call, I don't know how this gets done in nature, but it would be easy to do in a lab. They all get on this conference call, they get their story straight, and 3 days later, the very people who said this thing came from a lab change their tune and say that anyone who thinks that's crazy. Wow, that's a dramatic change in a matter of days, and the only real intervening event was this conference call that Dr. Fauci organizes. You know, it's bad enough when you have the truth and you don't share it, but what's worse is when you have the truth and you say things that directly contradict it. Dr. Fauci told us over the last several years it wasn't our tax dollars. Yes, it was. Right there's the grant to EcoHealth. He told us it wasn't gain of function. How about this email from NIAID, from Mr. Dazik, the head of EcoHealth, to NIAID, where he says, Dear Jenny, this is terrific. We are happy to hear that our gain of function research funding pause has been lifted. Dr. Fauci told us it wasn't a lab leak. Sure looks like it was. Sure looks like it was, and the people he's been handing out the money to, Mr. Anderson, Mr. Gary, said it was. And that's not to mention all the other crazy things he's told us. The vaccinated can't get it. The vaccinated can't transmit it. Boy, he was wrong about those. He told us that masks work. He told us that there was no such thing as natural immunity when it came to this virus. All kinds of things he told us wrong. So the lessons we learned is you can't trust some of the folks who were supposed to be giving us accurate information, because they sure didn't. And they knew from the get-go. They knew from the start. So I look forward to hearing from our witnesses. Look forward to seeing exactly what's in this report. That we didn't get into any of this. We didn't get into any of this. The chairman mentioned we can't look backwards. What we sure should look backwards, because if you got a government not giving it to you straight, that's something that you have to make sure we understand so it doesn't happen again. Not only we don't want a terrible virus happen again, we don't want the government misleading us about a virus that could happen. So we're going to look at this issue starting next month. We'll look into it. We'll make sure the country gets the facts like they should have had on February 1st, 3 years ago. With that, Mr. Chairman, I yield back.
Thank you very much, Mr. Jordan. I would like next to welcome today's witnesses. Dr. Rick Bright is an immunologist, vaccine researcher, and expert in pandemic preparedness. He served as Deputy Assistant Secretary for Preparedness and Response at the Department of Health and Human Services from 2016 to 2020. Dr. Bright previously served on President Biden's COVID-19 Advisory Board during the presidential transition in 2020 and 2021. Dr. Kizzmekia Corbett is a leading viral immunologist and vaccinationologist. She's previously worked as a vaccine researcher at the National Institutes of Health, where she played a key role in developing the breakthrough COVID-19 mRNA vaccine. She is currently an assistant professor of immunology and infectious diseases at the Harvard University School of Public Health. She's also an advocate for vaccine awareness and STEM education. Rebecca Dixon is a national leader in workers' rights advocacy. She currently serves as executive director of the National Employment Law Project, a nonprofit advocacy organization focused on building an inclusive economy with fair protections for workers. She is an expert in occupational segregation, workplace equity, and unemployment insurance. Admiral Brett Jywall served as Assistant Secretary for Health at the Department of Health and Human Services from 2018 to 2021, and is now CEO of Altesa Biosciences. Dr. Ngozi Ezike has worked for over 15 years to develop high-quality patient care to the people of Illinois and promote health equity within communities of need. She served as the director of the Illinois Department of Public Health from 2019 to 2022, guiding the statewide response to the coronavirus as the first Black woman to lead the agency. She is now president and chief executive officer of Sinai Chicago, where she continues to advocate for community-based public health initiatives and a robust healthcare system. Will the witnesses please rise and raise your right hands? Do you swear or affirm that the testimony you are about to give is the truth, the whole truth, and nothing but the truth? So help you God. You may be seated. Let the record show that all the witnesses answered in the affirmative. Without objection, your written statements will be made part of the record. Dr. Bright, you are now recognized for 5 minutes for your opening statement.
1,093,064 Americans have died from COVID since 2020. For all who have lost someone, this is more than a statistic. My dear mother, Jacqueline, died from COVID last year. We owe it to those we've lost and to those who have suffered to ensure that this never happens again. Chairman Clyburn, Ranking Member Jordan, and distinguished members of the subcommittee and the witness panel, it's a privilege to be here today. I'm Dr. Rick Bright, a career public servant and scientist who has served and spent 30 years addressing pandemic threats. For 10 years, I served in the Department of Health and Human Services and was the director of BARDA when the COVID-19 pandemic emerged. It is clear that the United States was unprepared for the COVID-19 pandemic. As I testified to Congress in May of 2020, we had a narrow window of opportunity to build a defense against COVID. However, the early response was chaotic and reckless, filled with denials, delays, and deceptions from government leaders and others entrusted to protect Americans. And politics prevailed over science. Our long underfunded healthcare system buckled, and we lost hold on two essential components of a response: speed and trust. And sadly, this led to many unnecessary deaths. Fortunately, we did some things well. Decades of public investment into technology platforms, support from Congress, and dedication of government and private sector scientists enabled rapid development of vaccines through Operation Warp Speed. Unexpected partnerships formed, unleashing a floodgate of solutions that will serve us for decades to come. The overall pandemic response warrants careful review. In addition to recent reports, Congress should authorize a nonpartisan commission to scrutinize and memorialize the details. The COVID-19 pandemic is not over. Infections, hospitalizations, and deaths are increasing dramatically, especially among older adults, the unvaccinated, and those who have not had their recent vaccine booster. Instead of declaring victory, we need to intensify efforts this winter. To save more lives, we must get more people fully vaccinated with COVID and flu. Provide clear guidance on testing, wearing a high-quality mask, and staying home when sick. Improve indoor air quality through proper ventilation and filtration. Continue robust testing and genomic surveillance. And we must ensure that all vaccines, drugs, tests, and masks are available, accessible, and free for all Americans. COVID will not be our last public health crisis. We must learn from the past and prepare for the future. The path ahead should include passing and funding proactive legislation, such as the Prevent Pandemics Act. And the federal government cannot do this alone. It's important to align federal, state, and local efforts with the private sector and global partners. Despite many challenges, I remain optimistic. I'm confident that science will enable a healthier, safer, and more equitable future. With scientific advancements from the pandemic, we can now make next-generation vaccines to reach more people and provide broader protection, develop new drugs for combination therapy, and host targeted treatments that strengthen our immunity to fight multiple pathogens, create more diagnostics for home use to bring the power of health monitoring into our daily routines, and detect infections earlier to guide treatment and reduce the risk of infecting others. And we can build a modern data infrastructure that strengthens and connects our healthcare systems and modern genomics. We can now see early signals of an outbreak weeks or months before it strikes to be able to fight it head-on instead of chasing after it. And we can produce vaccines and medicines locally to improve access and quality while reducing cost. Imagine adapting a warp speed model as a best practice for all healthcare needs. A better future is not just something to dream about. Congress, scientists, and American ingenuity can make all of this and more a reality. In the face of war, inflation, and climate change, we cannot abandon pandemic preparedness. We must act now to harness momentum gained through the crisis. We must never again be a nation unprepared. Thank you for doing your part.
Thank you, Dr. Bright. And we will now hear from Dr. Corbett. Dr. Corbett, you're now recognized for 5 minutes.
Good afternoon, members of the Select Committee on the Coronavirus Crisis and my fellow panelists. Thank you all, particularly Chairman Clyburn, for extending this invitation for me to serve as a witness in today's hearing. I am Dr. Kizzmekia Corbett, Assistant Professor of Immunology and Infectious Diseases at Harvard T.H. Chan School of Public Health. I often describe myself as a viral immunologist, which is just a fancy way of saying that I study the immune system's responses to viruses. I more specifically use my viral immunology expertise to inform the development of vaccines and therapeutics for coronaviruses and other viruses with pandemic potential. Most notable of my 17 years of experience is that, in the wake of the COVID-19 pandemic, my team and I at the National Institutes of Health co-developed both a leading COVID-19 vaccine and therapeutic antibodies. My firsthand experience as a frontline vaccine developer, and moreover, simply an empathetic human, is why I'm so grateful for you to have convened today to address how we might prepare for the next pandemic, particularly revisiting the lessons learned, both the good and the bad, from COVID-19. The truth is that while we would all like to put the pandemic behind us, one fact remains. The virus and the medical and social implications of it are here to stay. In fact, just in the past week in this country, we have averaged over about 60,000 cases per day. Yesterday, 400 of our beloved Americans died from COVID-related deaths. These stats come with the reality that we are currently in a season of high respiratory virus transmission and the so-called triple-demic of RSV, flu, and COVID. Atop of that, there are over 20 viral families that are constantly poised as pandemic threats. As time would tell, it is not a question of if another pandemic will arise, but when. Responding to continuous viral threats is certainly a task that, like COVID, is going to take scientific revolution, proactivity, and togetherness. I've long been passionate about answering scientific inquiries with experimental diligence and integrity. It is also important to me that that knowledge gained from those experiments is accessible and digestible to the general public. For many of us whose work straddles both basic science and public health, the pandemic awakened the direness of that necessity, the direness of getting it right, both in the science and with the outreach for the sake of humanity. And the work to get it right on both fronts continues. From a scientific perspective, we have learned several lessons. We are able to call upon years of scientific research to develop life-saving vaccines and therapies in record time. This, of course, would not be possible without funding directly, specifically, and targeted towards pandemic preparedness. Trusted collaborations between public and private entities, and strict and efficient regulatory efforts. It goes without saying that a plethora of scientific questions remain. What are the underlying causes of long COVID, which is estimated to still affect about 20 million Americans? How can we properly treat long COVID? How can we better predict and protect against variants? The continued need for scientific and technological breakthroughs is a reminder that we have to continue to zealously fund research not only for COVID-19, but all viral and bacterial and other diseases. This is a moment for us to turn the tide of traditional underinvestment in some research areas so that we are prepared in all fronts. As variants continue to emerge, we must prioritize development of universal vaccines and novel therapeutics. And because we are no strangers to each outbreak shining light on communities that have sometimes been neglected and overlooked, we must be strategic and unwavering in our efforts to increase health equity and tackle long-standing health disparities. From a community perspective, there are a plethora of outreach and communication that needs to be done. Only about 15% of eligible people have gotten their booster shot to date. We have to continue to emphasize the importance of increased vaccine uptake so that we can continue to save lives. On any given day, the fact that vaccines work is clouded with misinformation. So we have to continue to be creative in our approaches so that we meet people where they are with the facts. Thank you.
Thank you, Dr. Corbett. And we'll now hear from Ms. Dixon. Ms. Dixon, you're now recognized for 5 minutes.
Chairman Clyburn, Ranking Member Jordan, and members of the Select Committee, I thank you for the opportunity to testify today. I am Rebecca Dixon, Executive Director of the National Employment Law Project, also known as NELP. We are a nonprofit research, policy, and capacity building organization that for more than 50 years has sought to strengthen protections and build power for workers in the U.S., including workers who are unemployed. Although the COVID-19 pandemic caused enormous hardship for workers, families, and communities throughout the country, communities of color endured the harshest impacts due to compounding effects of longstanding structural racism across healthcare, labor, housing, education, and in the opportunity to accumulate generational wealth. As the subcommittee considers steps necessary to prepare for and prevent the next public health crisis, I urge you to recognize the impact of the programs that were critical supports during the most dismal days of the pandemic and the ways that both the coronavirus crisis and the underlying disparities and deficiencies that it exacerbated continue to impact workers and communities. Today, I will focus on the unemployment insurance program as well as paid sick, family, and medical leave programs that Congress authorized during 2020. The pandemic triggered the greatest job loss since the Great Depression. Black, Latino, Native American, and Asian workers, as well as women of all races, disproportionately worked in occupations and locations hardest hit by pandemic shutdowns and faced the highest rates of unemployment. Congress responded, creating temporary new UI programs that significantly expanded UI eligibility, and together with regular UI, enabled 4.7 million people, including 1.4 million children, to avoid poverty in 2020 alone. These programs expanded the reach, duration, and adequacy of UI benefits for all segments of the workforce, but particularly so for Black and Latino families who were traditionally disqualified or ineligible for benefits. For example, 1.2 million Latino workers and their families avoided poverty because of UI benefits in 2020. But despite substantial advances toward equity, the GAO found that troubling racial and ethnic disparities in accessing UI persisted during the pandemic. Antiquated technology, deficient staffing, outdated administrative practices all left state agencies ill-equipped to respond to the tens of millions of unemployed workers across the country. Congress did provide DOL with $2 billion in one-time funding to assist states in improving the functioning of their UI systems, and DOL has made excellent use of these funds, focusing much of its attention on efforts to make access to UI more equitable. Ongoing support is needed. To ensure that the UI system functions as it should at all times, especially during times of crisis, Congress must, 1, enact permanent reforms that establish minimum federal standards for eligibility, access, benefit duration, and adequacy. 2, appropriate sufficient administrative funds to strengthen the UI infrastructure at both the state and federal level. 3, reform and modernize the federal extended benefits program to automatically trigger on to provide additional weeks of benefits during economic downturns. And 4, establish additional emergency UI programs that automatically trigger on during periods of high unemployment. The paid sick and family medical leave programs created by Congress covered an estimated 22 to 60.5 million workers who desperately needed income support when they couldn't work, whether because of illness or caregiving needs. According to a study published by the journal Health Affairs, the guaranteed paid leave provisions decreased COVID-19 infections by 56% in the 38 states that previously had no paid sick leave guarantee, and stopping more than 15,000 daily infections nationwide. Guaranteed paid sick and family leave also enabled workers with caregiving responsibilities to remain attached to the workforce. However, the health and economic benefits could have been much greater if Congress had not created so many exemptions and had provided paid leave for longer durations and more types of care. Approximately 68 to 106 million workers were excluded from paid leave protections, weakening the economic and public health benefits of this law. In particular, a recent study by the Federal Reserve Bank of Boston found that large companies which did not voluntarily extend paid leave disproportionately employed women and workers of color. Congress should waste no time in enacting paid sick leave and family leave that applies to all workers. The pandemic proved the necessity of a strong UI program and paid sick and family and medical leave, and how instrumental they are to alleviating poverty, propping up businesses and communities. The economic lessons of the pandemic could not be any clearer, and Congress must implement these reforms to enable people across the country to weather the next health and economic crisis that we face. Thank you.
Thank you, Ms. Dixon. And we will now hear from Admiral Giroir. Admiral Giroir, you are now recognized for 5 minutes.
Chairman Clyburn, Ranking Member Jordan, members of the Select Subcommittee, and my fellow witnesses, all of us should be here today with a singular purpose, and that is to assure that, to the greatest extent possible, we can prevent the next pandemic. And if we cannot entirely prevent it, we must respond to it rapidly, effectively, justly, and with the least possible loss of life, educational and economic opportunities, and individual liberties. Globally, the United States must incentivize safe practices in live animal wet markets and BSL-4 laboratories. We must enforce agreements that ensure international transparency during early disease outbreaks. We must empower the WHO by adopting the plan I transmitted to the WHO Executive Board in September of 2020, and establish specific, strict safeguards on the funding of gain-of-function research, especially within adversarial nations. Domestically, in the future, there should never need to be a testing czar or an Operation Warp Speed. We can avoid that if we develop long-term, sustainable public-private partnerships, if we reform the unfocused, slow, insular, and operationally unprepared federal agencies, especially, unfortunately, the CDC, if we establish, before any crisis, a clear leadership structure and chain of command, and make state health agencies accountable for their funding with clear deliverables, metrics, and recommendations. Unfortunately, in my opinion, this subcommittee's report has not done enough to advance America's biosafety because it has ignored many critical questions and focused so much of its effort, like my entire 6-hour interrogation, on political scapegoating the Trump administration. This is not only unhelpful, but it is counterproductive by implying that the solution to this and future pandemics is just to replace a sitting president or follow the science, when we know that this is untrue. 420,000 Americans died from COVID during the Trump administration, of which I was a member, but 660,000 Americans have also died under the Biden administration, despite hundreds of millions of doses of vaccines, billions of tests, and life-saving oral antiviral drugs. Does this subcommittee really not believe it is appropriate to learn from the successes and the failures of the Biden administration, just as it did from the Trump administration? Indeed, there are numerous specific questions that Americans would like the Biden administration to answer, related to the collapse of the domestic test manufacturing infrastructure in early and mid-2021, the direct editing of official CDC guideline drafts by special interests, FDA's bypassing its external advisory committees when authorizing boosters, and the subsequent resignation of FDA senior officials, the vilification of the unvaccinated, and the delay in concluding that natural immunity is at least as protective as vaccine immunity, and many other questions. But even within the narrow scope of investigating the pandemic response during 2020, key questions have been entirely overlooked, such as what was the origin of the virus that caused COVID-19? Why was the United States the only eligible nation in the entire world without a representative to the executive board of the WHO when the pandemic began in China and we were desperate for information? Why did the FDA and Pfizer delay review of vaccine data and leave the elderly to die without protection for an unnecessary month? Why did candidates during the presidential election, along with much of the media, instill distrust about life-saving vaccines then in development by our administration? Finally, I would make the point that there is a critical difference between politicization of the science and political leadership of the scientific agencies. I was named HHS testing coordinator because of the abject failures of the CDC and the FDA in developing and scaling testing in February 2020. Within my 1 week, my multidisciplinary government team and private sector volunteers designed and implemented the National System of Community-Based Testing, 41 sites within days, expanding to over 7,000 sites within weeks. Was this political interference? In some sense, yes, but it was absolutely justified. Political leadership is why we have elected leaders, why government officials are vetted and confirmed by the Senate, to widen the lens of decision-making and to think holistically, taking into account all health and national consequences. And that is what we endeavor to do every single day. Thank you again for the opportunity to be here, and I look forward to an engaging afternoon.
Thank you, Admiral Giroir. And we will now hear from Dr. Ezike. Dr. Ezike, you are now recognized for 5 minutes.
Thank you. Thank you, Chairman Clyburn and the members of the subcommittee. I'm Dr. Ngozi Ezike, and I'm honored to be here today to share some perspectives from the COVID-19 pandemic. 6 months ago, I became president and CEO of Sinai Chicago, the largest private safety net health system in Illinois. For more than 100 years, Sinai has cared for the most underserved communities in Chicago, taking care of everyone regardless of their ability to pay. Prior to that, I served as the director of the Illinois Department of Public Health. IDPH is intentional about engaging disproportionately at-risk communities to tackle health disparities. These communities, whether they are rural communities, communities of color, economically under-resourced communities, these are often the same communities served by safety net hospitals. COVID-19 laid bare the health disparities that have historically plagued underserved communities. These communities face a disproportionate share of illness, of poverty, of hunger, as well as trauma. During the pandemic, thousands of hospitalizations and deaths in Illinois were patients with underlying chronic conditions. COVID-19, unfortunately, has widened the life expectancy gap between white and Black and brown communities. As we assess the lessons learned from the pandemic, we need to address our overall public health infrastructure We need to build up and maintain the public health workforce, and not just in times of pandemics or crises. We also need to support in the form of data modernization, and we need more effective communication and education. Prior to the pandemic, the public health system largely flew under the radar. Of course, COVID-19 has changed that perception, and today no one can minimize the impact of public health on everyone's life. When done right, public health is inextricably tied to promoting health equity. Whether because of viruses, unclean water, uncontrolled chronic diseases, food deserts, or violence, we see certain segments of our population endure greater tolls of morbidity and mortality. Aggressive, intentional action through partnerships and collaboration is essential to strengthen our public health infrastructure and make health equity a concrete, tangible action instead of just a feel-good catchphrase. When the pandemic hit at the end of my first year as the director of IDPH, my primary role turned to leading Illinois' public health response to the pandemic. My IDPH team and I shared many long days and nights reviewing large amounts of data and working to shape our response, educate people on both how to prevent spread, and later on when, how, why, and where to get vaccinated. At the same time, safety net hospitals like Sinai Chicago were struggling with limited resources and were stretched to the limits once COVID became part of their lives. Hospitals faced enormous numbers of people seeking treatment for this new virus. COVID has further highlighted the need to focus on addressing those issues of health equity, and I asked the subcommittee to consider the following priorities in evaluating the COVID response and using it to prepare for other emerging public health issues and crises. Communication, outreach, and education are critical components. We learned the importance of consistent, concise, and accurate information, and sharing it across a multitude of channels in multiple languages. At IDPH, we utilized trusted local voices and locations. In addition to public health leaders, we engaged with pediatricians, family doctors, but also sports coaches, community health workers, hair and nail and barber shops. We used churches, mosques, and synagogues. At Sinai, groundbreaking work was done to connect local residents with community health workers to help them navigate the health system and find the education and resources they needed to stay healthy and/or get the care they needed. We need more investment in communities to address infrastructure issues and bring down barriers tied to social determinants of health. We saw an issue regarding retail pharmacies. That was a major source of COVID testing and vaccinations. But Black and brown neighborhoods have fewer retail pharmacies, making it more difficult for those living there to access those resources and get the care they needed. We need continued community investment to address needs that impact people's health: jobs, housing, healthy food, neighborhood safety, and transportation. We need creative ideas and innovative solutions to ensure that everyone has access to quality care and that limited financial resources within a community do not equal limited lifespans. We need to incentivize physicians and nurses to work in under-resourced communities. We need to find ways to work to support staffing agencies while not bankrupting anchor hospital institutions that play a critical role. We need flexible funding for state, territorial, and public health agencies. Special funding is also critical to keep the safety net hospitals running, and we want to partner with our public health agencies for the betterment and the creation of healthier communities. Thank you, Chairman Clyburn and members of the committee, for your enduring work to learn and uncover our strengths as well as our opportunities related to our public health infrastructure and the care of the most vulnerable amongst us. I'm grateful for your consideration of the thoughts of myself and my esteemed colleagues on the panel today. Thank you.
Thank you very much, Dr. Ezike, and thank you, Dr. Foster, for standing in for me for a few minutes. So thank you so much. That ends witnesses, and we now will proceed to each member now having 5 minutes for questions. The chair recognizes himself for 5 minutes. Through my opening statement, I talked about some of the ways in which our country was not prepared for the coronavirus crisis. Now I want to focus on one area where we excelled. Breakthrough vaccine technology that had been in development for decades was put to use just days after the coronavirus was identified. Dr. Corbett, you were one of the leading scientists who used this technology to develop the breakthrough mRNA vaccine. Can you tell us how investments in the country had previously made in vaccine technology helped to prepare us for that moment?
Absolutely. Thank you. So while I was developing the mRNA vaccine technology, I was actually at the National Institutes of Health, which is obviously one of the federal government's intramural programs for biomedical research, at the Vaccine Research Center, which is one of the leading research centers for vaccine development in the world. Over the course of the last 20 years, since the Vaccine Research Center has been erected, funding towards development of vaccines such as the HIV vaccine, the respiratory syncytial virus vaccine, Ebola vaccine technologies, multiple other types of technologies have led to the funneling of a pipeline of technologies that have continued to advance and progress through the vaccine regulatory and development hurdles in record speed. Prior to the COVID pandemic, the VRC was notable at getting a Zika virus vaccine into clinical trial within months. And then upon this pandemic, because we had been studying coronaviruses for at least 8 years, and under my direction with the team for 5 years, we were able to monopolize on the technology and our understanding of other coronaviruses, transplant that knowledge, and use our understanding in order to get a vaccine into a clinical trial within 66 days after knowing the virus's sequence. That comes because that center is well-funded. That comes because people recognize and respect the work that comes out of that center. And that also comes because of other funding mechanisms such as CEPI and otherwise that were completely invested in understanding how we could deliver vaccines very quickly to the general public across the world in record speed, shall there be a pandemic. And I think, lastly, one of the things that is important to say as we think about pandemic preparedness is that one of the things that's important is that this could have been one of about 25 viral families that jumped into a human and caused a pandemic of sorts. It could have been a flu. It could have been a Bunya virus. It could have been an arteriovirus. It was almost lucky that it was a coronavirus and that we had invested money, resources, brains like mine and many other people on our team and nationwide and worldwide to studying coronaviruses. But had it been something else, we may not have been as lucky. And so what we need to do is we need to identify those potential pandemic threats. We need to be strategic about providing funding in multiple different directions, whether it be surveillance, vaccine technologies, therapies, organizations of infrastructure. We need to join together with low-income countries to build up their infrastructures as well so that we can prevent the spread of those threats, shall they start in other countries before they get to the United States. And we need to do this in a way that is expeditious and in a way that is organized so that everyone around the world understands how committed we are to preventing pandemics.
Well, thank you very much. I'm almost out of time, but can you give us some idea about what all is lurking out there in the universe, or how many viruses may be threats to us at this moment?
There are about, I say 24 viral families. Some other virologists say 22, give or take. Viral families that are lurking, that means that they hang out in zoonotic reservoirs, animals that don't necessarily get sick, but with a couple of mutations as these viruses evolve, They could jump into humans like ourselves, become infectious, and then spread, and that's something that we saw with the coronavirus pandemic.
And you don't think we were prepared for that?
Absolutely not. We quite frankly, Chairman, aren't even prepared for our seasonal flu epidemics.
Well, thank you very much for frightening me that way, but let me now yield to Mr. Jordan for questions.
Thank you, Mr. Chairman. Dr. Giroir, should we be sending money to China?
Broad question, but I think we should only be investing in research in places that are transparent. We have access to their scientists, at their database.
But you know what happened? American tax dollars went to EcoHealth. Hundreds of thousands of dollars went to the Wuhan Institute of Virology in Wuhan, China. Should we do that? I mean, just in a broad sense.
No.
The last 2 months, we got a $30-something trillion debt. The last 2 months, just interest to service that debt, the last 2 months was over $100 billion. And I think a lot of American taxpayers are asking, why are we sending hundreds of thousands of dollars to a lab in China? Can't we do that here in the United States, some of that research, or all that research?
So let me be clear. There is no way we should be funding gain-of-function research in Chinese
that was my next
laboratories
question.
that are not transparent.
Well, how about at a lab that's not up to code? I mean, we have communications not from China, from our embassy, saying serious shortage of appropriately trained technicians at this lab, and yet we send them American tax dollars. Should that happen?
In my opinion, no, it should not happen at all.
And how about gain-of-function research? You were starting. I apologize. I interrupted you. Go ahead, Doctor.
Well, gain-of-function research, my big issue with gain-of-function research is there's no transparent process to review it. It's reviewed by the scientists who fund it. It's not open. There are no standards Congress needs to set in. And that's for all gain-of-function research in the United States. There is no possibility we should be, in my opinion, funding gain-of-function research in non-transparent adversarial nations that could have covert weapons programs, et cetera, to use it against us.
No kidding. Well, so you sort of answered what I was going to ask next. I think I know your answer. Should the P3 interagency review process, should that have been bypassed?
No, and in fact, it needs to be strengthened, made more transparent, and have multidisciplinary people on the panel, not just the scientists regulating themselves. I think it's very problematic when any discipline regulates itself. This is much broader, and I do think Congress has a big role and would like to see them more active in this.
I want to just read, this is slide number 6 behind me. I'm going to read this. NIAID re-reviewed the grant application and other information provided by you. Now, this is from Health and Human Services to EcoHealth. NIAID re-reviewed, but the interesting word, which sort of suggests it was reviewed once, and they reached a conclusion, and then re-reviewed the grant application, other information provided by you, and made the following assessment, quote, the experiments to generate MERS-like and SARS-like coronaviruses are not subject to the HHS P3CO framework. Do you agree with that assessment?
I don't, but I like to get to the root causes. Number one, we need to know who's on the panel. It needs to be multidisciplinary. It needs to be transparent. All those things need to happen, and then you would not have a result like this.
You know how many times the PC3, according to Dr. Cadlick, you know how many times they actually reviewed some grant proposal?
Actually, I don't know that answer.
According to Dr. Cadlick, twice, 2 times. So bypassing wasn't the exception, it was the norm. I mean, and it wasn't even the norm, it was just a practice. It was just like an interagency panel that was in name only because they didn't do anything. So Dr. Fauci was making all these decisions, and yet they still had to write this email saying we re-reviewed. Quite the thing there. What would you say is the biggest lesson, if you could say one thing, I got an idea what I want to say, but what would you say is the biggest lesson learned from this terrible virus that impacted all aspects of our lives, and as you point out, 6 million people, took 6 million people's lives?
I don't know if there's one large lesson. One thing I would say, let me focus domestically, because there's a whole lot of things globally. Domestically, we did suffer in investment in the public health system for a long period of time, but it's not just money, it's accountability, metrics, leadership. The second big issue is we failed to engage the private sector throughout our preparations, and that the federal agencies in general performed incredibly poorly. And all of us need to look at that and reform, because that's a root cause. If we don't fix leadership in federal agencies, it doesn't matter the fabulous vaccines and local care, the federal government will fail the country.
And is there anyone, any names in particular who you think particularly failed the country?
I think the CDC had an enormous learning curve and needs to be reformed. Great people, incredible people, smart people. The organizational culture, the reactivity, the operational capability was really below standard, and I want to put the luster back on that agency.
Let me just read the last paragraph from your testimony. You just read it a few minutes ago, because I think this is an important lesson we need to learn. Political leadership is why we have elected leaders. Now, you thought that was so important. It was the closing point in your presentation in the last hearing this committee is going to have. It is the people whose names get put on a ballot who make decisions, or, as you point out in your testimony, people whose names get put on a ballot and then nominate people for high positions in our government who are confirmed by people whose names were on a ballot and who were elected by we the people who should be making the decisions. That was the point you were making right there.
That is
that
the
right?
point I was making, and I think this has been confused and confabulated in the report. This country needs leadership by elected officials and by appointees.
That's how our system works, but that
That's
is
how
not
it
what
works.
happened.
You
That is
cannot-
not what happened
you
over the
cannot
last
have
3
a
years relative to
person-
this pandemic.
you
It was
cannot
people
have
who
a
never,
person-
I'm sorry, go ahead.
You cannot have a person in a
Mr. Jordan?
cubicle with a narrow focus running a national response. That doesn't work.
I appreciate you making that the final point of your presentation because it's right on target. I yield back.
Thank you, Mr. Jordan. The chair now recognizes Ms. Waters. Ms. Waters, Ms. Maloney for 5 minutes.
Chairman, thank you for calling this important meeting.
She's not there.
The coronavirus pandemic brought economic devastation to many American families, inflicting the most harm on those who were already struggling. Many essential workers, including people who worked at grocery stores and assistants, bus drivers, and so forth, were unable to work from their homes. So they were at an increased risk, and particularly post office workers became particularly sick because of this coronavirus. And these workers were also more likely to lack critical benefits like paid family leave that would have helped them get by if they or their family members became ill. Ms. Dixon, can you tell us what impact the lack of paid family leave had on frontline workers during the coronavirus crisis? Ms.
Sure.
Dixon?
Sure. So we all saw in places like New York City where people clapped and banged pots. But what those workers need from us is to show up and provide paid leave so that they can take care of their families when they have sick children, so that they are not having to choose between rent and going to work sick. So that is the impact, and it is critical that we have paid leave available to all workers in this country.
Well, as the mother of 2 daughters, I know the difficulty of balancing work and family, and have put in legislation my whole time in Congress for this paid leave for workers. We did finally pass it with Clyburn's help for all federal workers, but we need to expand that to all workers. And an analysis of the select subcommittee released earlier this year found that workers who did not have access to paid leave quit their jobs at a far higher rate than workers who did have access to paid leave during this time. Mrs. Dixon, I'd like to ask, does this finding surprise you? And can you tell us more about how enacting universal paid leave will help to better protect the American families?
It did not surprise me. Workers, especially workers in low-paid jobs, they have very little rights and they have very little benefits, and I would include paid leave among those. And so when they need to take time off, they often are getting written up and fired. So in some cases, they quit, but in some cases, they are also fired. And so that is not a surprise. And we can actually make a difference for working people by making this benefit that is available to a lot of us in this room available to those workers as well. And we should not say that these workers are essential and then treat them as disposable.
Well, the Select Committee's final report which we will be voting on today, recommends that we make paid leave, medical and family leave universal for all American families in the United States. And I agree with that completely. For a country that talks about work-family balance, that talks about family values, the programs really are not there to support the families. Dr. Ezike, you've been a leader in state and local public health for more than 15 years. In your experience, how could access to paid leave improve health outcomes for people and families working to make ends meet? We know that the pandemic has been hard for so many families, particularly low-income ones, and it's very hard on women, especially. During the early months of the pandemic, women lost 4 times as many jobs as men. 2 years later, women are still struggling to return to their jobs, compounded by a lack of affordable childcare and without access to paid leave. Data from the same select subcommittee analysis found that female hourly workers experienced worse employment outcomes than their male counterparts, both before and during the pandemic. These are compounded, these problems are compounded for women of color. Ms. Dixon, can you tell us how women, and particularly women of color, disproportionately bore the brunt of the pandemic, and why paid family leave is so important and essential for them? Mrs. Dixon.
I sure can. We know that women of color, particularly Black women, are in some of the lowest paying jobs with the least flexibility. And so when this pandemic hit, they had to choose between being home to supervise their children on Zoom school or going to work. They had to choose between taking care of a sick child who is being quarantined and paying their rent. They had to make those horrible choices. And in this country, we should not do that. We need to modernize these programs. We need to stop pretending like we have an all-male workforce from the 1950s and change this policy to make sure that working women's needs are taken care of and front and center.
Well, my time has expired, but I agree that we need a national paid leave program to build an equitable, resilient economy. Thank you, Mr. Chairman, for your report and for your focus today. I yield back, Mr. Clyburn.
Thank you very much. The chair now recognizes Dr. Miller Meeks for 5 minutes.
Thank you, Mr. Chair, and I'd also like to thank all the witnesses for appearing here today. It's interesting to listen to the lessons learned from the pandemic, because the lesson I learned and I take away from the pandemic is one which I predicted in the end of April of 2020, and that is that lockdowns and the way we proceeded to address the pandemic would end up costing more lives than would actually we would see succumb to COVID-19. And we, in fact, have seen that in the loss of lives from cancer screenings that did not take place, heart attacks, strokes, and this data has all been out there, diabetes. We correctly, myself and others correctly predicted that the increase in mental illness, depression, anxiety, and suicide would occur. We also predicted an increase in drug overdoses, drug dependency, and deaths from drug overdoses. In San Francisco, it's been in the San Francisco Chronicle reported ad infinitum that ages 18 to 45, the group that is not tremendously affected by COVID-19, has had more deaths from drug overdoses, far in excess of what they have had to COVID-19. What we did not predict, and can any of our witnesses even address, do you know why the Las Vegas school system opened up last year when they were going to stay closed? The reason was because from March 16th till June of 2021, they had 6 youth suicides, and from July 1st to December 31st of 2021, they had a total, or 2020, they had a total of 12 suicides, 18 suicides in 9 months, the youngest of which was 9 years old. 9 years old. The Head Start program continued to mask 3- and 4-year-olds who are at very little to infinitesimally no risk of developing illness or hospitalization from COVID-19 unless they are in a high-risk population. So we have a program which we're continuing to advocate for to lock down. We've already seen in China that lockdowns don't work, and massive protests against how they treated their population and their individuals and their liberty. And yet, we still don't even know where the virus came from, how it emanated, and in talking about how to prepare for the next pandemic, how to respond to the next pandemic. And Dr. Giroir, you had correctly addressed the fact that the CDC, and I'm a former director of the Department of Public Health in Iowa, and a military veteran, so I know something about pre-positioning supplies, strategic national stockpile, responding to emergencies, that, you correctly addressed that the CDC, an exemplary organization, wonderful in research and global international threats, was unable to take research, applications, develop testing, and develop messaging for what people could and could not do. We already had information on the CD side about whether masks work or did not work. We have asked, and I have asked in this committee of both Dr. Fauci and Dr. Walensky about infection-acquired immunity, which we know is a real thing. But yet, it seems like our CDC continued to deny that that was, in fact, something that was knowledgeable. So my question to you is, do you think we've adequately addressed where COVID-19 came from? And given testimony that you've given before, are you concerned about where COVID-19 came from and access that the Chinese Communist Party has to different viruses, and whether or not they're using these for nefarious purposes?
Well, first, yes, I think after probably 20 million worldwide deaths, we need to know where this virus came from, because if we're going to prevent it in the future, not just rely on all the countermeasures that we have to understand. And lab leaks are common, not just in China, but they're common all over, which is why I think all BSL-4 laboratories need to have some international standards and cooperation. The second point is, and this gets back to my DARPA days and DOD days before I was here, but there are many rogue states and countries with bioweapons offensive programs. My assessment is China is one of them, and there are many others. And these are as much of a risk to us as naturally occurring infections. And again, that supports all the research and innovation that needs to have here. So yes, this is a concern, and China is a concern on both of those grounds.
Thank you very much. And I think in preparing for the next pandemic, it's just as important to recognize that viruses come from a variety of places, some from nature and some from laboratories. Thank you so much. I yield back.
The chair now recognizes Mr. Raskin for 5 minutes.
Mr. Chairman, thank you very much. And thanks to our witnesses today, especially my constituent, Rebecca Dixon. Thank you for joining us. Before turning to the final report, I wanted to address a disturbing announcement that came out of Florida yesterday. Governor DeSantis has requested that the Florida Supreme Court convene a grand jury to, quote, investigate crimes and wrongs in Florida related to the COVID-19 vaccines and further recommend enforcement methods. On top of this, Governor DeSantis is forming a so-called Public Health Integrity Committee to oversee the medical establishment. Florida Surgeon General, a prominent critic of vaccine safety, will oversee this new Orwellian super committee. These actions are transparently designed to falsely suggest that coronavirus vaccines, and not the coronavirus itself, are dangerous. But these vaccines have saved millions of lives, yet some public officials are continuing to promote distrust, dangerous misinformation, and conspiracy theory. Dr. Corbett, as one of the developers of a coronavirus vaccine, do you agree that these actions are troubling?
As I said in my opening statement, I absolutely agree that vaccine misinformation is troubling. And as you stated those statistics, I just wanted to read off a little bit more because obviously I came with them. So as of yesterday, there was a report based on modeling. Just in the United States, vaccines have saved over 3 million lives. In August of this year, unvaccinated people reportedly died at 6 times the rate of those who got at least the primary series of the vaccine. And unvaccinated people aged 50 or older were 12 times more likely to die than vaccinated and double boosted peers. So we hear a lot about things like natural immunity and versus vaccine immunity. And the one thing that I like to say is that they are not in competition with each other. The point of a vaccine is so that you can teach your natural immune system how to recognize a virus without having to get that virus, or at least to get a very nasty infection or severe illness from that virus. So vaccines are a way to prevent that type of disease, very severe disease.
Well, I appreciate your clarification. The final report describes the committee's findings on how President Trump and members of his administration exerted sharp pressure on public health officials during the first year of the pandemic, preventing them from speaking to the press and even altering or blocking public health guidance and CDC reports. Members of the administration rejected proven public health measures and advocated for disproven and fraudulent treatments like the drug hydroxychloroquine, even after it was shown to be ineffective and potentially dangerous. Dr. Bright, you saw some of these efforts yourself during the early months of the pandemic, and you were one of the officials who pushed back against them. Can you tell us more about what you've witnessed in terms of medical disinformation and misinformation and the implications that they have for our public health?
Yeah, thank you for that question. It is no doubt that the misinformation and the politicization of information about life-saving medical countermeasures, including our drugs and our vaccines and our masks, have caused many unnecessary deaths. We know that in order to get the information needed to use a therapy or a treatment, we need to have a randomized controlled clinical study. And in those early days, there was a lot of pressure to utilize or distribute hydroxychloroquine or other unfounded treatments before we had the critical clinical trial data. And there was great risk of not only not effectively treating people who were infected at the time, but also causing potential additional harm. But it's the misinformation, it's the lies about the drugs and vaccines and masks from the early days that have eroded trust across this country, that has put hesitancy in the space between a life-saving drug or vaccine and a person actually getting that drug or vaccine. And that trust is hard to rebuild, and because of that gap, we're seeing many Americans die who did not need to if they could have just had the truth about the effectiveness of those drugs and vaccines at the beginning.
Thank you. I'm afraid my time is up. I'll yield back to you, Mr. Chairman.
I thank the gentleman for yielding back. The chair is now going to have a 5-minute recess. The chair determines the recess to be over and will now recognize Ms. Waters for 5 minutes.
Thank you very much, Mr. Chairman. Before I raise my question, I'd like to thank you for the work that you've done in chairing this very, very special committee. You have been able to provide the leadership to give transparency to some of the faults that we have experienced during this pandemic. And so I'm very pleased that I've had the opportunity to work with you, and I believe that the report that you will be putting out today will be very helpful in basically informing us on what we need to do for the future. Again, thank you very much. I have a question.
Thank you.
You're welcome. I have a question that really has almost been answered. And the question is, when the coronavirus pandemic began, racial minorities experienced higher rates of infection and death rather than other groups. In the first half of 2020, the death rate among Black and Latino people was much higher than for white people in every age category. So this is a question for Dr. Ezike. You led the public health response in Illinois during the critical juncture. Did you observe these inequities, and what was the cause of poor outcomes in the communities of color? When I listened to your testimony, I heard some of the answers to the questions that I'm raising. But I'd like to just add a little bit to the question to have you share with us your opinion about whether or not we have too much bureaucracy in the health business, number one. And number two, yes, we know that Blacks and Latinos have died disproportionately. We know that seniors receiving Medicare even are overwhelmed with paperwork that they cannot handle. So what can you tell us about, of course, the death rates and about the bureaucracy?
Thank you. We absolutely did see a significant increase in the mortality rates in our communities of color, in our Black and brown communities compared to their white counterparts. As Ms. Dixon shared, some of that is related to the absence of sick leave. While many people were able to stay at home, a lot of the members of the Black and brown communities had to go to work every day. And going to work every day in the early days of the pandemic, when there wasn't adequate testing, obviously there was no vaccine, that was obviously a prime opportunity for exposure and subsequent spread and illness and worse. So we saw that definitely there. We also had, some difficulties getting out the right information to allow people to understand ways that they could protect themselves, to try to promote contact tracing. Again, as all of those things were slow in getting off the ground, there are people who suffered the consequences. But again, I think it's foundational that when you tell someone that they're sick, or when someone knows that they're sick, but also knows that staying home and in an effort to try not to spread it might result in them becoming homeless, not be able to put food on the table for their children, that's a false choice that everyone will make the choice to continue going to work, whether sick or not. And so again, it really circles and puts a fine point on the need for paid sick leave. But tackling the health inequities also involves dealing with the baseline chronic diseases that are higher in our Black and brown communities. The higher rates of diabetes and cardiovascular disease and obesity are also significant, and we need to address those health conditions as well.
Thank you so very much. I yield back.
I thank the gentlelady for the E in the back and thank her very much for her comments. The chair now recognizes Representative Foster for 5 minutes.
Thank you, Mr. Chair, and to you and your staff for your contributions to this this select committee. It is when I look at all of the issues that came up during the time we were developing and dispensing vaccines, you know, there were a number of candidates that fell by the wayside. Things like oral vaccines, things like nasal spray vaccines, that seem to, you know, had they been available, I think we would have sidestepped a lot of the difficulties we saw. We wouldn't have the huge problems with having to keep them heavily refrigerated that we saw with at least the early versions of the mRNA. The ability to just administer a nasal vaccine, my feeling just from talking to people is that you would have had a lot less vaccine hesitancy. That a lot of what we saw for vaccine hesitancy actually was needle hesitancy somehow in disguise. Because when I found that, you know, I would try to convince people to get vaccinated and then end up, after long discussions, not succeeding, when I asked them, well, what if it was a pill or a spritz up the nose? And they, oh, sure, I'd do that. And so when you look at what's desirable for future vaccines, if we could just go down, what would your dream vaccine look like, and where should we really put our effort and into next generation vaccines? Dr. Corbett.
So specifically for coronaviruses, which is a respiratory pathogen, one of the reasons why many people lean towards the idea of having either an oral or a nasal vaccine, aside from decreasing what is called vaccine hesitancy, is being able to hopefully impede upon transmission by inducing what is called mucosal immunity. That is a level of immunity that is here in your nose or and around your mouth. I think that those types of vaccine technologies are far out. While there are people, scientists, companies working on those types of technologies, the development of those types of technologies are not at the place, and certainly we're not at the place where they would be developed very quickly, like the mRNA vaccines or other types of technologies.
You know, you go to war with
but
the
in my
army you have,
my
so.
ideal vaccine would be a vaccine that covers some level of breadth for the known variants of coronaviruses and other variants of coronaviruses that may pop up. A vaccine that could be a technology that is more accepting, whether that is a protein-based vaccine, intranasal vaccine. I am all for having technologies being advanced that generally people will be more accepting of. And lastly, a vaccine technology that is affordable or free for all people. That's my ideal vaccine.
Okay, Admiral Giroir, do you want to have a swing at
Yes, sir.
Yeah, just continue. Yeah, what would you like in a next generation vaccine? What should we be shooting for?
Yeah, I think I would echo all those comments. I'm just going to make answer a question that you may not want, but I think the kinds of things you talk about are really sort of high-risk platform ideas, and Congress generously funded ARPA-H this year for those kind of platform things. The mRNA vaccine was funded originally by DARPA when I was there and right after that. And to make that big step, I agree with the professor that we're not quite there yet. It's not mainstream, but these kind of fundamental technical investments to allow an intranasal vaccine or one that you could apply with a Band-Aid, those are possible, and those are high-risk investments that maybe 10 or 15 years from now, we will have forgotten about needles. And I agree, a lot of my people in my family, they get a needle, they pass out, and it's a big jump. So I think when we get out of that, we'll be in good shape.
Thank you. Dr. Bright?
Yeah, I thank you for that important question, because we have spent years working on intranasal vaccines and oral delivered vaccines and transdermal delivered vaccines for the right reasons. They can be low cost. Actually, you can stimulate different types of immunity. This can be broader spectrum and can be longer lasting. So we need vaccines that are broad spectrum, long duration of immunity, that are low cost, that are room temp stable, and provide something that can be scalable and produced around the world so we can respond as quickly as possible. The challenge has always been that we default to pouring the largest investments in the most proven technologies, and we fail to then use that momentum or use some of those funds to bring these next generation technologies forward. And then the crisis goes away, the money goes away, and those next generation technologies are still left in the holding gate. That's why we need another warp speed-like event or organization to identify these next generation candidates with those properties and get those over the finish line so we have a broader spectrum of vaccines for everyday diseases and the pandemics of the future.
Thank you. And I guess I'm out of time here, and I should add to your wish list to have a Congress that has an attention span a little longer than a mayfly. Yield back.
Thank you, gentlemen, for yielding back. The chair now recognizes Mr. Jordan for any closing statement he may want to make.
Thank you, Mr. Chairman. Mr. Chairman, would it be okay if I ask a couple more questions instead of a closing statement?
Yes, you may.
Thank you, Mr. Chairman. I appreciate that, that courtesy. Dr. Bright, when the Biden administration told us that the vaccinated couldn't get the virus, were they guessing or lying?
Congressman, there were data in real-world clinical trials in healthcare workers that showed when they were vaccinated with this vaccine, it did prevent both asymptomatic and symptomatic infection. So at the time, the vaccines were preventing infection, but as we know, the virus changed, and the vaccine immunity, we learned, also waned.
When the Biden administration told us that the vaccinated couldn't transmit it, were they guessing or lying with that one?
There were data to support in the early days of the vaccine that the vaccine could prevent infection and transmission.
Were you in the administration when that was happening?
I was not in the administration
But
when
you
the
just know this.
vaccines
You just
were
know this.
distributed.
Was it misinformation to tell the American people something that wasn't true? You talked a little bit ago with questioning from Mr. Raskin, you talked about misinformation. Was it misinformation to tell the American people things that just aren't accurate relative to not just the vaccine and whether you could get it and the vaccine and whether you could transmit it, but also about natural immunity? Was that misinformation?
From the earliest days of this outbreak, Americans have been lied to, sir.
No, but I'm asking, was it that, with those things from the Biden administration, they clearly said, the president said, if you get the vaccine, everything's going to be fine. Was that a guess or a lie? That's what I'm asking.
It is actually proven that the vaccines save lives. So if you are vaccinated—
That's not what I'm asking. I'm asking when the statement the president made was that if you get the vaccine, you won't get the virus. And that's obviously not true.
Well, we
Was
know
that
today—
misinformation?
No, sir. What we know today is vaccines are still saving lives.
Was it a true statement?
We know that the virus has changed and mutated.
I'm not saying that. I appreciate the vaccine, and I think it's helped. I certainly do. I'm not saying that. I'm just saying what they said was that misinformation, because you had a nice misinformation discussion with Mr. Raskin a few minutes ago.
Sir, as I said, there have been a lot of misinformation from public health officials throughout this pandemic.
No kidding. No kidding. Dr. Giroir, you earlier when Mr. Raskin asked Dr. Bright a question, they said that people in the Trump administration, experts, scientists in our government were prevented from talking to the press. Was that your experience?
It was not my experience at all.
Well, it certainly wasn't the American people's experience, particularly with one official in our government. I don't know if you could go a day, I don't know if you could go an hour without seeing Dr. Fauci on TV for maybe a year and a half. It still happens, maybe not with quite the frequency. So he certainly wasn't barred from talking, was he?
No, to my knowledge, he was not.
No, he's everywhere. He was like man of the year, man of the decade, man of the century. He was all kind of every cover of every magazine. So he certainly was out there. You weren't. There wasn't any gag order put on you. You were allowed to talk, weren't you?
I was, and I went to any place that wanted me on TV, whatever their affiliation, time, whatever. I did it because that was part of my job.
Well, Dr. Bright, did they tell you couldn't talk to anyone?
Yes, they did, sir. We were gagged. We were not allowed to speak to the media. All media requests were declined.
Why do you think that was the case? Why were you gagged and Dr. Giroir wasn't?
I have no idea, sir, but
well, let me ask you this. Who did you directly report to in your, at BARDA?
I reported to Bob Cadlick, the ASPR. the Assistant Secretary for Preparedness Response.
Dr. Cadlick, you reported to. Well, when we deposed Dr. Cadlick, he said he had doubts about your integrity. Would that have anything to do with why you weren't allowed to talk to the press and Dr. Giroir was?
Sir, it's unfortunate Dr. Cadlick is saying this proven.
Well, he said it under oath in a deposition. You saying he was lying?
I'm saying what he said was untrue, sir.
Wasn't true? Did you actually approve a contract without going through proper channels at the HHS, without talking to Secretary Azar, Dr. Redfield, Dr. Cadlick, Dr. Fauci, Dr. Wong? Did you do
I absolutely did not. Dr. Cadlick signed off on each of those contracts, sir. That was our protocol. I was not allowed to, as BARDA director, to sign a contract over a certain dollar limit.
Did you negotiate or look in possible employment opportunities while you were still working at BARDA?
That's another unfortunate truth in Dr. Cadlick's testimony.
It's not true, huh?
An unfortunate lie in Dr. Cadlick's testimony, sir. I was not negotiating any employment while I was negotiating contracts.
Who was that contract
In fact,
with that there was a discrepancy over?
I have no idea what Dr. Cadlick thinks in that area,
It was
sir.
with Johnson & Johnson relative to COVID countermeasures.
And I never
You
sought
disagree with that?
employment with Johnson
Did you
&
seek
Johnson.
employment with Johnson & Johnson?
I did not, sir.
Okay, just want to get that clear. But you weren't allowed to talk to the press, but everyone else was.
Not everyone else was,
Dr.
sir.
Giroir was.
Dr. Giroir might have
Dr.
been.
Fauci was.
Perhaps.
Perhaps I saw him every day. Dr. Birx was. Saw her every day on TV. Dr. Redfield saw him all the time.
Sir, many civil
But you weren't allowed to.
scientists- Many civil servants, scientists
Dr.
were not
Giroir
allowed.
was.
Many scientists from the CDC were not allowed to speak.
Was
to
it
the public.
misinformation? Was it misinformation then when, again, to the I think the fundamental question, when the Biden administration told the American people that if you get the vaccine, you won't get the virus? Was that an accurate statement? Let's just say that. Was that an accurate statement when they told us that?
The truth is, sir, that the vaccines are highly effective at reducing
Was it
hospitalizations.
an accurate statement to say, if you get the vaccine, you won't get the virus? That came from government officials, and you were the one who brought up misinformation. I didn't.
Sir, I think now we know that if
Time,
you are
Mr.
vaccinated,
Jordan.
that you can still get infected.
Your time has expired.
I didn't say we didn't. Thank you, Mr. Chairman. I appreciate the courtesy. I yield back.
Thank you, gentlemen, for yielding back. Now, those questions were in place of Mr. Jordan's closing statement, so I will proceed to mine. In a moment, we will conclude this hearing and turn to our business, during which we will formally adopt the Select Subcommittee's final report. Before we do that, I want to thank all of today's witnesses for their testimony. Your insight into what our nation must do to prepare for the next public health emergency has been invaluable as we prepare to conclude the committee's work. I also want to thank the members of the Select Subcommittee for joining me in this important endeavor over the past 2.5 years. I'm also grateful for the Biden administration's leadership in guiding us out of the coronavirus crisis. Our nation is in a far better place than we were in January 2021. Now we must take action to prevent such dark days from returning in the future. With that, without objections, all members will have 5 legislative days within which to submit additional written questions for the witnesses to the chair, which will be forwarded to the witnesses for their response. This hearing is adjourned. Now, witnesses, you are excused, and we will ask that your places be taken by the clerk. will come to order. Without objection, the chair is authorized to declare a recess of the committee at any time. Pursuant to notice, I now call up the committee report. The clerk will report the report which has been distributed in advance.
Preparing for and preventing the next public health emergency, lessons learned from the coronavirus crisis. Final report, December 2022.
Without objection, the report is considered read and open to amendment at any point. The chair recognizes himself to offer an amendment in the nature of a substitute, copies of which have been distributed electronically to all members in advance. The clerk will report the amendment.
Amendment in the nature of a substitute to preparing for and preventing the next public health emergency, lessons learned from the coronavirus crisis report, offered by Mr. Clyburn.
Sorry about that. Without objection, the amendment is considered read and will serve as base text for purposes of amendment. I now recognize myself. The findings of the Select Subcommittee detailed in this final report, based on first-hand accounts, contemporaneous records, expert testimony, and other evidence, identify pre-existing vulnerabilities, failures in leadership, and predatory actions that contributed to extraordinary loss of life and economic suffering during the crisis. The Select Subcommittee has acted as an effective steward of public funds, identifying billions of taxpayer funds spent ineffectively, inefficiently, or inequitably within pandemic relief programs across the federal government. As this final report shows, in many instances, the Trump administration's poor management of relief programs left them particularly vulnerable to waste, fraud, and abuse. The report also lays out in detail how the previous administration prioritized politics over public health in its pandemic response, engaging in an unprecedented campaign to undermine federal agencies responsible for protecting Americans' health and lives. Importantly, the report also lays out recommendations to combat the many instances of fraud, abuse, and interference that plagued the country's pandemic response. George Santayana famously observed, "Those who cannot remember the past are condemned to repeat it." We must remember the shortcomings in our response to the coronavirus crisis so we do not repeat them in our responses to future crises. I commend the work of the Select Subcommittee over the past 2 years and the vital work of its members and staff. We have worked tirelessly to ensure that our country will be better prepared for the next public health emergency. Thank you, and I yield back. Does anyone seek recognition?
Mr. Chairman.
Mr. Jordan?
Thank you, Mr. Chairman. Wish to speak on the report?
You may.
Thank you, Mr. Chairman. The report's long on bashing President Trump, but there's nothing in the report about the cause of this virus, nothing in the report about the origin, nothing in the report about American tax dollars being sent to China, nothing in the report about this dangerous gain-of-function research concern, nothing in the report about just what happened at the start, what we know. American tax dollars went to a company that wasn't properly vetted, that didn't comply with its grant contract, who then sent money to a lab in China that wasn't up to code and did gain-of-function research, and that lab in Wuhan, China, is the place where this virus most likely started. Nothing in the report about that. I find that just amazing. The Select Committee on Coronavirus, the only select committee in the Congress on this virus, doesn't want to look at how the thing started. Nothing in the report about any of that. Nothing in the report about Governor Cuomo's nursing home order. And we know what happened there, the tragic situation, tragic things that happened there. Nothing in the report about CDC colluding with the teachers union. Nothing in the report about the impact of the vaccine mandate on our country, the impact of the vaccine mandate on our military. Nothing in the report about that. So I'll be voting no on this report because I don't think it got to what this committee should have focused on. And frankly, I think a lot of Americans think the same way. I appreciate the chairman yielding, and we'll yield back our time, but we'll be voting no on the report. Mr. Chairman, I need a unanimous consent request, if I could. Mr. Chairman?
You're asking for unanimous?
Yeah, request unanimous consent that all members have 2 calendar days in which to submit additional views, including minority or dissenting views.
Just, Mr. Jordan, before we get to that, I think Ms. Maloney.
Oh, okay.
Thank you, Mr. Chairman, for recognizing me. And I just wanted to thank you and the committee members for their participation in this subcommittee and particularly for your leadership over the past 2.5 years. You conducted diligent oversight, and that is reflected in this committee's final report. It captures the challenges that our country has faced during the coronavirus pandemic.
Yeah, that's fine.
And among the report's 30 recommendations is that critical investments are needed to address the coronavirus and to prepare for future public health emergencies. So we need to reinvigorate a chronically underfunded public health system to improve our nation's ability to prevent and respond to future crises. The report, I want to point out, also recommends that we modernize our public health data collection and disease surveillance capabilities, and that we grow and support our public health workforce. These, along with other recommendations in the report, are very important measures. I hope that my colleagues on both sides of the aisle will work together to implement these recommendations so we can prepare for future challenges and improve our ability to protect all Americans in the case of another virus attacking us. Again, I want to thank you for the in-depth analysis, the many hearings, the professionals that you brought before us, and I support your report.
Thank you very much. If no one else is seeking recognition, we'll move to a vote. The question now occurs on the amendment in the nature of a substitute to the committee report. All of those in favor, say aye.
Aye.
All those opposed, say no.
No.
In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. The question now occurs on favorable reporting the committee report as amended. All those in favor, say aye.
Aye.
All those opposed, say no.
No.
In the opinion of the chair, the ayes have it. Let the record reflect that Mr. Jordan opposed favorable reporting this report by voice. The committee report shall be favorably reported to the House. Without objection, a motion to reconsider is laid upon the table. Without objection, staff is authorized to make technical and conforming changes to the matters considered by the committee in this markup.
Mr. Chairman.
Mr. Jordan.
Thank you, Mr. Chairman. I ask unanimous consent that all members have 2 calendar days in which to submit additional reviews, including minority or dissenting views. Thank you.
Without objection. There being no further business, I want to thank all of you for your participation today. With that, the committee stands adjourned.